Hi, my name is Julie Clark, and today I am going to present my capstone project on reducing readmission rates of diabetes patients. Readmission rates are high for patients living with diabetes for many reasons, and these rates are growing across the state of Tennessee as we see more diabetes patients receiving that diagnosis in the state of Tennessee. These readmissions cause financial hardship and struggles for healthcare organizations, which include hospitals, nursing homes, and home health. Patients diagnosed with diabetes are required to learn new processes of how to monitor and control their health status, and this can be confusing to them due to literacy levels and financial strains, and maybe even noncompliance due to beliefs and biases and things that they have within themselves. So as caregivers, we need to look for a way to provide better education, better tools and resources so that they can be successful. This is a graph showing Tennessee newly diagnosed diabetes patients. These are adult age patients, and it's starting from 1994 and moving across to 2016. You can see in the data here that the newly diagnosed rate is going up and has steadily been increasing over these years. So my proposal to this issue is to develop and implement a community coalition collaboration work group that would meet virtually and develop programs to help patients newly diagnosed with diabetes within that community. These strategies might include providing lifestyle coaches, which could be educators and encouragers along with the patient while they are learning their new diagnosis. They could help monitor weight, activity level, and food choices, and help improve the patient's efforts in monitoring and controlling their health outcomes by being an active member in the program with the patient in learning new lifestyles. Providing evidence-based education, support, and resources to patients and caregivers throughout the process of living with diabetes. So this can look like many different things, and the Community Coalition work group would meet to develop these, but I see community-wide diabetes awareness campaigns focused on working with the community to bring awareness on how not to move into a diabetic diagnosis. You might even have pre-diabetes care education that's provided once the patient becomes at risk for diabetes. And then at start of diagnosis and throughout their life, follow-up and education tools and resources for these diabetic patients. And then following the data that is provided in the work group meetings, this group could provide even more education on topics that are specific to that community's needs. Improve engagement and compliance with new and lifelong health strategies. This is possibly looking at use of electronic devices to help the patients be able to monitor and change their lifestyles. Then you can follow the data if you're on this work group for trends in poor health approaches, including obesity levels and physical activity levels. There's data that is publicly available for that. And engage physicians to gather data and survey data through their office visits, so collecting information at that point of care with the patient that has diabetes. This is an example of a publicly available data set, and this is showing physical inactivity for adults age 20 and older. So this is broke down by county level, it looks like here. So you can see the darker blues are the areas that have the most physical inactivity. This type of data could be used by the work group to make improvements if this is an issue in their specific county level. So there is a decision-making team and the roles that they would have. I have this shared in the presentation today. The Centers for Medicare and Medicaid Services, or CMS, Quality Improvement Organization, QIO, can help to facilitate these virtual meetings and provide data from CMS to the meetings. And then, of course, they can assist with any quality improvement steps, which would look like root cause analysis, PDSA, and more. Community hospitals, nursing homes, and home health could be at the table as decision makers, and their role would also be to provide readmission data and other data from their organizations that are related to this diabetes patient demographic. And then, of course, they can provide feedback in the meetings on what is meaningful and what is working towards the improvement efforts. Community physician practices that treat diabetes patients could also serve as a decision-making person in this group, and then also provide some data during their routine care, what they're seeing with the diabetes patients, and then help with us in implementing a good diabetic practice of care because of the knowledge that they have being physicians. Representation from the Diabetes Association would also be great to have on this decision-making team. They can also help spread awareness across the community and across the nation and be a reliable source on up-to-date diabetes information. And then diabetic patients and caregivers and their families, I would say that they would be the most important decision maker, the person that needs to be at the table and the person helping to make the decisions on how the process will move. And so I've shared a little bit of the data, but there are other data that can be collected during this process to make sure that the project is moving in the right direction and that we're getting the outcomes that we are wanting. So one of them is the community readmission data from healthcare organizations, and I spoke to that just a moment ago. This would look like the hospitals, nursing homes, home health agencies bringing their own organization's data on readmissions with diabetic patients, how often that occurred, what were the reasons, that type of thing. CMS also has publicly available data that the CMS QIO could bring to the meeting. Lifestyle change data submitted by the diabetic patient, so surveys conducted during routine visits at the physician's office or even during the life coach sessions could be utilized to capture anything that maybe the diabetic patient has been able to implement in their life and the areas that they're struggling with. Satisfaction surveys of the program from all of the people that are involved, so that would be the patients, staff, and healthcare organizations. This needs to be routinely collected and reviewed just to make sure that the group is working towards mutual goals and everyone is satisfied with the process. Compliance rate data collected by physicians through their patient care visits. So this might also include glucose level data, vital signs at these visits, and any other information that could help direct the work group in which directions they should go for education, support, and resources. And then again, CDC has data that's provided through the CMS QIO that could be shared during these meetings to help with decision making as well. So the outcome I would like to see is that working together in collaboration across all these healthcare organizations, the improvement work will benefit everyone involved in the program, with the readmission rates decreasing for hospitals and nursing homes and home health. And the patients are going to enjoy a better health outcome in their community because they are going to be burdened less with this illness that they are going to hold on to for the rest of their life. This is my reference that I had for the data shared today in the meeting. And again, I want to thank you for coming and listening to my presentation. Goodbye.